discuss the recurrent miscarriages, the RCOG guideline. Okay, the first thing which we have to discuss in this guideline is the definition of the miscarriage, which is in the background and introduction of this guideline. Okay, so what is miscarriage? Miscarriage is defined as spontaneous loss of pregnancy before the fetus reaches viability. Okay, and the term therefore include all pregnancy losses from the time of conception until 24 weeks of gestation. Okay, and it should be noted that advances in the neonatal care have resulted in a small number of the babies surviving birth before 24 weeks of gestation. Okay, so when the birth of the baby is before 24 weeks of gestation, means before the age of the viability, that is called the miscarriage. Okay, and now what is recurrent miscarriage? Recurrent miscarriage is defined as the loss of 3 or more consecutive pregnancies that affect one person of the couple trying to conceive. Okay, now what is the incidence of the recurrent miscarriage? It has been estimated that 1 to 2% of the second trimester pregnancy miscarry before 24 weeks of gestation. Okay, 1 to 2% of the second trimester miscarriages before 24 weeks of gestation, and after 3 first trimester miscarriage, okay, the next pregnancy, the chance of next pregnancy is 30%. Okay, now identification assessment of evidence, I think it would be better if we leave it. The important thing which we need to discuss are the risk factors for recurrent miscarriages. Okay, what are the causes of the recurrent first trimester miscarriages and recurrent second trimester miscarriages? There are many different causes. Okay, so first of all, epidemiological factor. Okay, what are the 2 independent risk factors for recurrent miscarriages? Maternal age and the number of the previous miscarriages are the 2 independent risk factors for the further miscarriage. And it's very important that advancing maternal age is very important. Advancing maternal age is associated with the decline in both the number and quality of the remaining oocytes. Okay, and prospective register linkage study reported that the age-related risk of pregnancy is recognized and pregnancies to be about at the 12 to 19 years there is 13%, and at 20 to 24% there is 11% risk of miscarriage, and 20 to 29 years there is 20% risk of miscarriage, 30 to 34 years there is 15% risk of miscarriage, and 35 to 39 years there is 25% risk of miscarriage, at 40 to 44 years there is 51% risk of miscarriage, and when the age is more than 45 there is 93% risk of miscarriage. Now, what is the role of advancing paternal age? Advanced paternal age have also been identified as a risk factor for miscarriage, and the risk of miscarriage is highest among the couple where the woman is more than 35 years old and the man is more than 40 years of the age. Okay, now another important thing is that previous reproductive history is an independent predictor for the future pregnancy outcome, and the risk of the further miscarriage increase after each consecutive pregnancy loss, that is reaching approximately 40% after 3 consecutive pregnancy losses, and the prognosis worsen with increasing maternal age, and a previous live birth do not preclude the woman developing recurrent miscarriages. Okay, now what are the important environmental factors? The evidence on the effect of the environmental risk factor is based mainly on the data studying women with sporadic rather than recurrent miscarriage, and the results are conflicting and biased by difficulties in controlling for the confounding factor and inaccuracy of the data on exposure and measurement of the toxin dose. Maternal cigarette smoking, caffeine consumption have been associated with increased risk of spontaneous miscarriage in dose-dependent manner. However, the current evidence is insufficient to confirm this association. And heavy alcohol consumption is toxic to the embryo and fetus, and even the moderate consumption of the 5 units per week may increase the risk of the sporadic miscarriage. Okay, now another important thing is that working or using video display terminal does not increase the risk of miscarriage, and the evidence of the anesthetic gases for the theater worker is conflicting. Okay, and about obesity, retrospective studies have reported that obesity increases the risk of both sporadic and recurrent miscarriages. Okay, so we have discussed several important things. Okay, first of all, the maternal age, then paternal age, and previous reproductive history, the environmental factor, and that the effect of the cigarette smoking, caffeine, alcohol, video display, terminal working in those area, and anesthetic gases effect, and the obesity. So we have discussed these things in epidemiological factor. Now coming to the antiphospholipid syndrome, which is very, very important. Antiphospholipid syndrome is the most common treatable cause of recurrent miscarriages, and which antibodies should we check for? The antiphospholipid syndrome refers to association between antiphospholipid antibodies and lupus anticoagulant and anticardiolipin antibodies and anti-beta 2 glycoprotein 1 antibodies and adverse pregnancy outcome or vascular thrombosis. Okay, and what can be the adverse pregnancy outcome in patient with APLS? Okay, the adverse outcome include 3 or more recurrent miscarriages before 10 weeks of gestation, 1 or more morphologically normal fetus after 10 weeks of gestation, and 1 or more preterm birth before 34 weeks of gestation owing to placental disease. Now, what is the mechanism by which antiphospholipid antibodies cause pregnancy morbidity? Mechanism by which antiphospholipid antibodies causes pregnancy morbidity include the inhibition of trophoblastic function and differentiation and activation of the complement pathway at the maternal fetal interface, resulting in the local inflammatory response, and at the later pregnancy thrombosis of the uteroplacental vasculature. Now, what is the role of heparin? In vitro studies have shown that the effect of antiphospholipid antibodies on trophoblastic function and complement activation is reversed by heparin. Now, what is the incidence of the presence of antiphospholipid antibodies in the patient with recurrent miscarriages? Antiphospholipid antibodies are present in 15% of the women with recurrent miscarriages. By comparison, the prevalence of the antiphospholipid antibodies in the woman with a low risk of static pregnancy is less than 2%. Okay, in the women with recurrent miscarriages associated antiphospholipid antibodies, the live birth rate in women with a no pharmacological intervention has been reported to be as low as 10%. Now coming to the genetic factors, okay. Parental chromosomal rearrangement. Okay, what is the incidence of the balanced structural chromosomal abnormality? In about 2 to 5% of the couples with recurrent miscarriages, one of the partners carries balanced chromosomal anomalies, commonly balanced reciprocal or Robertsonian translocation. And what complications can result in the patients with a balanced translocation? Okay, although the carriers of a balanced translocations are usually phenotypically normal, their pregnancies are at increased risk and may result in a live birth with a multiple congenital malformation or mental disability secondary to unbalanced chromosomal rearrangement, and the risk of the miscarriage is influenced by the size and genetic content of the rearranged chromosomal segments. Now coming to the embryonic chromosomal abnormalities incidence. In couples with recurrent miscarriage, the chromosomal abnormality of the embryo accounts for 30 to 57% of the further miscarriage. Okay. Now what is the role of the age? The risk of miscarriage resulting from the chromosomal abnormality of the embryo increases with advancing age. Okay. And role of previous reproductive history, that is important. Okay. So it's written that, however, it is important to note that the number of recurrent miscarriages increases as the risk of euploid pregnancy losses increases. Okay, anatomical factors, congenital uterine abnormalities. Okay, and the exact contribution of the congenital abnormalities may to recurrent miscarriages remain unclear, since the prevalence and reproductive implication of the uterine anomalies in the general populations are unknown, and the reported prevalence of the uterine abnormalities in the recurrent miscarriage population ranges from 1.8 to 37.6%. Okay, and and this variability reflects the differences in the criteria and technique for the diagnosis, and the fact that the variable studies have included the women with 2, 3 or more miscarriages in both first and second trimester pregnancy. Okay, the prevalence of the uterine abnormalities appear to be higher in women with the second trimester miscarriages compared to the women who suffer from the first trimester miscarriage, but this may be related to the cervical weakness that is frequently associated with the uterine malformation. Now coming toward the type of the anomalies, it has been reported that women with the RCOG uterus tend to miscarry more in the second trimester, while women with a subtate uterus are more likely to miscarry in the first trimester. Now, what is the term delivery rate in a patient with uterine abnormalities? A retrospective study of the reproductive performance in the women with untreated uterine anomalies have suggested that these women experience a high rate of the miscarriage and preterm delivery with a term pregnancy rate of only 50%. However, retrospective studies are biased by the patient selection, and until well-controlled prospective data become available, the role of uterine anomalies in the recurrent miscarriage will remain debatable. Okay, in pregnancy with fibroid, the rate of the miscarriage is approximately 14%. Okay, now coming to this cervical weakness. What is the incidence of the cervical weakness? Cervical weakness is a recognized cause of the second trimester miscarriage, but there are two incidences unknown since the diagnosis is essential and essentially a clinical. Okay, and there is currently no satisfactory objective test that can identify women with a cervical weakness in non-pregnant state, and the diagnosis is usually based on the history of the second trimester miscarriage preceded by the spontaneous rupture of membrane or painless cervical dilatation. Okay, and cervical. Okay, now coming to the endocrine factors. Okay, systematic endocrine disorders such as diabetes mellitus and thyroid diseases have been associated with miscarriages. Women with diabetes who have high hemoglobin HbA1c in the first trimester are at the risk of miscarriage and fetal malformation. However, well-controlled diabetes mellitus is not risk factor for the recurrent miscarriages, nor its treatment, nor is related to the thyroid dysfunction. Okay, the prevalence of the diabetes and thyroid dysfunction in women who suffer from recurrent miscarriages is similar to that reported in the general population. Okay, now coming to the role of anti-thyroid antibodies in causing recurrent miscarriage, this small paragraph is about that. Okay, anti-thyroid antibodies have been linked to the recurrent miscarriages. However, one data control study from 1998 have reported that women with recurrent miscarriages are no more likely than the women without recurrent miscarriages to have circulating thyroid antibodies. And a single prospective study has shown that the presence of anti-thyroid antibodies in the euthyroid women with a history of recurrent miscarriages does not affect the future pregnancy outcome. Okay, now another very important, is there any role of PCOS in causing miscarriage? Polycystic ovarian syndrome has been linked to an increased risk of miscarriage, but the exact mechanism remains unclear. Polycystic ovarian morphology, elevated LH hormone or serum testosterone level, all the marker of PCOS do not predict an increased risk of the future pregnancy loss among the ovulatory women with a history of recurrent miscarriage who conceive spontaneously. Now, we will discuss what factor increase the risk of miscarriage in women with PCOS. Okay, that is written here. Okay, the causes of miscarriages in the women with PCOS is written that the increased risk of miscarriage in the women with PCOS has been attributed to them. First of all, insulin resistance. Secondly, hyperinsulinemia. Insulin is more in them. There is insulin resistance and hyperandrogenemia. Okay, and the prevalence of insulin resistance is increased in women with recurrent miscarriage compared with the matched fertile control. An elevated free androgen index appear to be a prognostic factor for the subsequent miscarriage in a woman with the recurrent miscarriages. Okay, now immune factors. Okay, what test for the immunological markers should not be performed in a woman with recurrent miscarriages? There is no clear evidence to support the hypothesis of human leukocyte antigen incompatibility between the couple, the absence of maternal leukocytotoxic antibodies, or the presence of the maternal blocking antibodies, and hence they should not be offered routinely in the investigation of couple with recurrent miscarriages. Okay, so these antibodies do not have very profound role. Now, natural killer cells are found in the peripheral blood cell and uterine mucosa. Peripheral blood natural killer cells are phenotypically functionally different from the uterine natural killer cell. There is no clear evidence that the altered peripheral blood natural killer cells are related to the recurrent miscarriages. Therefore, testing for peripheral blood natural killer cells are as a surrogate marker of the evidence of the maternal-fetal interface is inappropriate and should not be offered routinely in the investigation of the couple with the recurrent miscarriages. Okay, now what is the role of the uterine natural killer cells? It has been suggested that the uterine natural killer cells may play a role in the trophoblastic invasion and angiogenesis, in addition to being an important component of the local maternal immune response to pathogens. It should be noted that the largest study examining the relationship between the uterine natural killer cells number and the future pregnancy outcome reported that the raised uterine natural killer cells number in the woman with recurrent miscarriages was not associated with increased risk of miscarriages. And this remains a research field, and testing for the uterine natural killer cell should not be routinely offered in the investigation of the recurrent miscarriages. Now, what are the cytokines? Cytokines are in fact the immune molecules that control both immune and other cytokine response are generally characterized either as helper 1 Th1 type with the production of the pro-inflammatory cytokine interleukin 2 interferon and tumor necrotic factor alpha as T helper 2 with the production of anti-inflammatory cytokine interleukin 4, 5 and 10. It has been suggested that the normal pregnancy might be the results of predominantly Th2 cytokine response, whereas the women of the recurrent miscarriages have a bias towards the mounting Th1 cytokine response. Okay. And a meta-analysis concluded that the available data are not consistent with a more than modest association between cytokine polymorphism and recurrent miscarriages. And further research is required to assess the contribution that disorder cytokine make the recurrent miscarriages, okay, before the routine cytokine test can be introduced into clinical practice. Now coming to the role of infective agents. Any severe infection that leads to the bacteremia or viremia can cause sporadic miscarriage, and the role of the infection in recurrent miscarriage is unclear. Now, how are the infective agents involved? For an infective agents to be implicated in the etiology of repeated pregnancy loss, it must be capable of persisting in the genital tract and avoiding detection, or must cause insufficient symptoms to disturb the woman. Now, toxoplasmosis, rubella, cytomegalovirus virus, herpes, and listeria infection do not fulfill these criteria, and routine TOR screening should be abandoned. Now, what is the role of bacterial vaginosis? Okay, the presence of bacterial vaginosis in the first trimester of pregnancy has been reported as a risk factor for the second trimester miscarriage and preterm delivery, but the evidence for association with the first trimester miscarriages is inconsistent. And a randomized placebo-controlled trial reported that the treatment of bacterial vaginosis early in the second trimester with oral clindamycin significantly reduces the incidence of the second trimester miscarriage and preterm birth in the general population. There is no published data to assess the role of antibiotic therapy in the women of the previous second trimester miscarriages. Okay, now inherited thrombophilic defect, these are very important. Okay, what are the 5 established causes of the systemic thrombosis? Both inherited and acquired thrombophilia, including activated protein C resistance, most commonly due to factor 5 latent mutation, the deficiencies of protein C and S, antithrombin 3, and hyperhomocystinemia and prothrombin gene mutation are established causes of systemic thrombosis. And in addition, inherited thrombophilia have been implicated as a possible cause of recurrent miscarriages and late pregnancy complications, with the presumed mechanism being thrombosis of the uteroplacental circulation. Okay, a meta-analysis of the pooled data from 31 retrospective studies suggested that the magnitude of the association between inherited thrombophilia and fetal loss varies according to the type of the fetal loss and the type of thrombophilia. The association between thrombophilia and the late pregnancy loss has been consistently stronger than for the early pregnancy loss. Now, factor 5 laden. Okay, these are certain sort of study. Now coming to the important points that methyl N-tetrahydrofolate mutation and protein C and antithrombin deficiencies were not associated with the fetal loss. However, since protein C and antithrombin 3 deficiencies are rare, the number of the women included in these studies were too small to show any difference in the pregnancy outcome. Now, double risk. Similarly, another meta-analysis of 16 control studies reported that the carrier of the factor 5 laden and prothrombin gene mutations have a double risk of experiencing a recurrent miscarriage compared with a woman without these thrombophilic mutations. Now, outcome of untreated pregnancy. Prospective studies of the outcome of untreated pregnancies in the woman with hereditary thrombophilia are scarce. And one study, 6 hereditary thrombophilia reported no adverse effect on the live birth rate of the woman with recurrent miscarriages. By contrast, the 2 small retrospective studies reported an increased risk of miscarriage in untreated pregnancy for the women with recurrent miscarriage who carry factor 5 latent mutation compared with those with a normal factor 5 genotype. Now, what are the recommended investigations of the couples with recurrent first trimester and second trimester miscarriages? Women with recurrent first and second trimester miscarriages should be looked after by the healthcare professional with the necessary skills and expertise where available. This might be within the recurrent miscarriage clinic. And the loss of the pregnancy at any stage can be devastating experience, and the particular sensitivity is required in assessing and counseling the couples with recurrent miscarriages. Ideally, the couple should be seen together at detailed recurrent miscarriage clinic and giving accurate information to facilitate decision making about the future pregnancy. Clearly written patient information leaflets are recommended to provide written information that the couple can take to home. Now, antiphospholipid antibodies. Okay, which women should be screened before pregnancy for the recurrent miscarriage? All women with recurrent first trimester miscarriages and those with a one or more second trimester miscarriages should be screened before pregnancy for antiphospholipid antibodies. And what test gives the confirmed diagnosis of antiphospholipid antibodies? To diagnose antiphospholipid syndrome, it is mandatory that woman has to test at least 12 weeks apart either lupus anticoagulant or anticardiolipin antibodies of immunoglobulin G or immunoglobulin M class present in the medium or high titer over 40 gram per liter or ml per liter or above 99 percentile. Now, Russell upper venom time test. Okay, in the detection of the lupus anticoagulant, the dilute Russell Viper venom test together with the platelets neutralization procedure is more sensitive and specific than either activated partial thromboplastic time test or kaolin clotting test. Anticardiolipin antibodies are detected using standard enzyme linked immunoglobulin acid. What can be the interlaboratory variations in the detection of the antiphospholipid antibodies? In the detection of the antiphospholipid antibodies is subject to the considerable interlaboratory variation, and this is the result of temporary fluctuation of the antiphospholipid antibody titer in the individual woman and the transient positive secondary to the infection and suboptimal sample collection and preparation and the lack of the standardization of the laboratory test for their detection. Now, karyotyping. What sample should be used for the cytogenetic analysis? Cytogenetic analysis should be performed on the product of conception on the third and subsequent consecutive miscarriages. In what cases parental peripheral blood karyotyping of the both parents should be used? Now, parental peripheral blood karyotyping of the both partners should be performed in the couple with recurrent miscarriages where testing of the product of conception reports an unbalanced structural chromosomal abnormalities. Okay, now it's very important that the knowledge of the karyotype of the product of conception allows an informed prognosis of the future pregnancy outcome to be given. And while a sporadic fetal chromosome abnormality is the most important cause of any single miscarriage, the risk of miscarriage as a result of the fetal aneuploidy decreases with increasing number of the pregnancy loss. If the karyotyping of the miscarried pregnancy is abnormal, there is a better prognosis for the next pregnancy. Now, a Dutch study reported the couples with a balanced translocation have a low risk 0.8% of the pregnancy with an unbalanced karyotype surviving into second trimester, and that the chance of having a healthy baby is 83%. A recent prospective UK audit of 4 UK centers over the period of 5 to 30 years reported that the balanced translocations were found in 1.9% of the parents with the recurrent miscarriages, but only 4 balanced translocations were found after referral for the prenatal diagnosis because of the balance parental translocation ascertained for the recurrent miscarriage. Okay, now coming to the anatomical factor, which patient should have pelvic ultrasound done to assess the uterine abnormalities? So all the women with recurrent miscarriages, first trimester miscarriages, and all the women with one or more second trimester miscarriages should have pelvic ultrasound to assess the uterine anatomy. Now, what further investigations are needed to check for the uterine abnormalities? Now, suspected uterine anomalies may require further investigation to confirm the diagnosis using hysteroscopy, laparoscopy, or 3-dimensional pelvic ultrasound. Okay. Now, a review of the studies comparing the diagnostic accuracy of the various imaging modalities have reported 2-dimensional ultrasound scanning and or hysteroscopy can be used as an initial screening test. Combined hysteroscopy and laparoscopy and the possibility of 3-dimensional ultrasound scanning should be used as a definitive diagnosis. The value of the MRI remains undetermined. Now, what tests for thrombophilia are advised? Women with the second trimester miscarriages should be screened for inherited thrombophilia, including factor V laden, factor II prothrombin gene mutation, and protein C. A meta-analysis of the retrospective studies have reported a strong association between the second trimester miscarriage and inherited thrombophilia, factor V laden, factor II prothrombin gene mutation, and protein S deficiency. Now, treatment option for recurrent miscarriages. What are the treatment options for recurrent miscarriages, first and second trimester miscarriages? Women with recurrent miscarriage should be offered referral to a specialist clinic. Now, antiphospholipid syndrome. Pregnant women with antiphospholipid syndrome should be considered for the treatment with a low-dose aspirin plus heparin to prevent further miscarriages. A meta-analysis of the randomized control trial examined the outcome of the various treatment, including aspirin, steroids, intravenous globulin, and heparin, given to improve the pregnancy outcome of the women with recurrent miscarriages associated with antiphospholipid antibodies. The meta-analysis reported that only treatment or treatment combination that leads to a significant increase in live birth rate among the women with antiphospholipid syndrome is aspirin plus unfractioned heparin. And this treatment combination significantly reduces the miscarriage rate by 54%, aspirin plus unfractioned heparin compared with aspirin alone. Okay, and two small retrospective studies reported no difference in the efficacy and safety between unfractioned heparin and low molecular weight heparin when compared with aspirin in the treatment of women with recurrent miscarriages associated with the antiphospholipid antibodies. And the value of the heparin has been questioned in two studies. However, there are methodological weaknesses in both demographic and laboratory entry criteria at the time of randomization. What adverse effect of the aspirin and heparins are there? There is no adverse fetal outcome reported in the meta-analysis of the randomized control trial of the low-dose aspirin for the prevention of preeclampsia in pregnancy. Heparin does not cross the placenta, and there is no potential to cause a fetal hemorrhage or teratogenicity. Heparin can, however, associate with maternal complications including bleeding, hypersensitivity reaction, heparin-induced thrombocytopenia and osteopenia and vertebral fracture. Okay. Now, these are some studies, leave those things. And corticosteroid. Can corticosteroid nor intravenous, neither corticosteroid nor intravenous immunoglobulin therapy improve the live birth rate of the woman with recurrent miscarriages associated with antiphospholipid antibodies compared with the treatment modalities, and their use may provoke significant maternal and fetal morbidity. Okay, and these are all the study, so we can leave it. Okay, coming to the genetic factors. What should be done in case of the abnormal paternal karyotype that is written? The finding of an abnormal paternal karyotype should prompt referral to a clinical genetics. Okay, and genetic counseling offer a couple a prognosis for the future pregnancies with unbalanced chromosome complement and an opportunity for familial chromosomal studies. Okay, and reproductive options in the couple of chromosomal rearrangement include proceeding to a further neutral pregnancy with or without prenatal diagnostic test, gamete donation, and adoption. Okay, what is the role of the pre-implantation genetic diagnosis? Pre-implantation genetic diagnosis has been proposed as a treatment option for the translocation carrier, and since peri-implantation genetic diagnosis necessitates that the couple undergo in vitro fertilization to produce embryo, couples with a proven fertility needs to be aware of the financial cost as well as implantation and live birth rate per cycle following in vitro fertilization and peri-implantation genetic diagnosis. Furthermore, they should be informed that they have a higher 50 to 70% chance of the healthy live birth in the future and to reach pregnancy following the natural conception than in the currently achieved after peri-implantation genetic diagnosis and in vitro fertilization, which is approximately 30%. Now, peri-implantation genetic screening in vitro fertilization treatment in women with unexplained recurrent miscarriages does not improve the live birth. Peri-implantation genetic screening in conjunction with the in vitro fertilization has been educated as a treatment option for women with recurrent miscarriages, and the rationale being that identification and transfer of what are thought to be genetically normal embryo will lead to a live birth. The live birth rate of a woman with unexplained recurrent miscarriages who conceive naturally is significantly higher than currently achieved after peri-implantation genetic screening in vitro fertilization, 20 to 30%. Anatomical factors. Congenital uterine malformation. There is insufficient evidence to assess the effect of the uterine septum resection in women with recurrent miscarriages and uterine septum to prevent further miscarriages. There is no published randomized controlled trial assessing the benefit of the surgical correction of the uterine abnormalities on the pregnancy outcome. Open uterine surgery has never been assessed in reproductive trial but associated with the prospective infertility and carriage carries a significant risk of uterine scar rupture during pregnancy, and these complications are less likely to occur after transcervical hysteroscopic resection of the uterine septum, and experience from the case series appear promising. However, before a clear judgment can be made, this procedure must be evaluated in prospective control trial. Now, cervical cerclage weakness and cervical cerclage, the role. What complications are associated with the cervical cerclage? Cervical cerclage is associated with the potential hazards related to the surgery and the risk of stimulating uterine contraction, and hence should be considered only in the women who are likely to be of benefit. Okay, now a woman with a history of second trimester miscarriages and suspected cervical weakness who have not undergone history indicates cervical cerclage may be offered serious cervical sonographic surveillance. In women with a singleton pregnancy and a history of one second trimester miscarriage attributed to the cervical factor, ultrasound indicated cerclage should be offered if cervical length of 25 mm or less is detected by the transvaginal scan before 24 weeks of gestation. Okay, now coming to a little bit explanation of this point, the role of the cervical cerclage in prevention of the preterm birth has been examined in recently published RCOG Green Top Guideline. Okay, prophylactic cerclage role is written that the Cochrane review of 4 randomized control trial found no conclusive evidence that prophylactic cerclage reduces the risk of the pregnancy loss and preterm delivery in women at the risk of preterm birth or mid-trimester loss owing to the cervical factor. Furthermore, the procedure was associated with a high risk of minor morbidity but no serious morbidity. A small reduction in the deliveries before 33 weeks of gestation was noted in the large trial, and the benefit was most marked in the women with a 3 or more second trimester miscarriages or preterm birth. However, there was no significant improvement in the perinatal survival. Now, what is the role of the cervical length on TVS? A large cervical length on the TVS during pregnancy may be useful in predicting the preterm birth in some cases of suspected cervical weakness. A meta-analysis of the individual patient level data from 4 randomized controlled trials reported that the subgroup analysis of the woman with singleton pregnancy and the short cervical length of less than 25 mm and previous second trimester miscarriage cerclage may reduce the incidence of the preterm birth before 35 weeks of gestation. Okay, transabdominal cerclage has a very important role in some cases, has been advocated as a treatment of second trimester miscarriage and prevention of early preterm birth in selected women with the previous phase cervical cerclage and short and scared cervix. In absence of any control group, the reported improvement in the pregnancy outcome is difficult comparison. In systemic review, compare the abdominal and vaginal cerclage in a woman with a failed vaginal cerclage in previous pregnancy, and this review concluded that the abdominal cerclage may be associated with a lower risk of the perinatal death at delivery before 25 weeks of gestation and a higher risk of the serious operative complication. Whether to perform a transabdominal cerclage before pregnancy or during pregnancy remains unclear. Now, coming toward the endocrine factors. Okay, there is insufficient evidence to evaluate the effect of the progesterone supplementation in the pregnancy to prevent a miscarriage in a woman with recurrent miscarriages. Okay. Progesterone is necessary for the successful implantation and maintenance of pregnancy. This benefit of progesterone could be explained by immunomodulatory action in inducing a pregnancy productive shift from pro-inflammatory Th1 cytokine response to a more favorable anti-inflammatory Th2 cytokine response, from Th1 to Th2 response. Okay, Th1 is not favorable and Th2 is favorable. Okay. Now, a meta-analysis to assess the progesterone support for pregnancy showed that it did not reduce the sporadic miscarriage rate. However, in the subgroup analysis of the trial involving the women of recurrent miscarriage, progesterone treatment offered a statistically significant decrease in the miscarriage rate compared with the placebo or no treatment. However, this meta-analysis was based on the 3 control studies. None of these detected significant improvement in the pregnancy outcome. Okay, a large multicentric study is currently underway to assess the benefit of the progesterone supplementation in women with unexplained recurrent miscarriages, and there is insufficient evidence to evaluate the effect of the HCG in the pregnancy to prevent the miscarriage in women with recurrent miscarriages. And a large multicentric placebo-controlled study of the HCG in the early pregnancy failed to show any benefit in the pregnancy. However, another small placebo-controlled study stating that the benefit of the HCG is confirmed to a small subgroup of women with recurrent miscarriages and oligomenorrhea. And HCG supplementation in early pregnancy should be used only in the context of randomized control trial. Now, suppression of the luteinizing hormone among the ovulatory women with recurrent miscarriages and polycystic ovaries does not improve the live birth rate. And luteinizing hormone hypersecretion, a frequent feature of the PCOS, has been reported as a risk factor for the early pregnancy loss, and a randomized control trial has shown that the pre-pregnancy pituitary suppression of luteinizing hormone among the ovulatory women with recurrent miscarriages and polycystic ovaries who hypersecrete luteinizing hormone does not improve the live birth rate. Furthermore, the outcome of the pregnancy without the pituitary suppression is similar to that of the woman with the raised luteinizing hormone. There is insufficient evidence to evaluate the effect of the metformin supplementation in pregnancy to prevent the miscarriage of women with the recurrent miscarriages. Okay, and the increased risk of miscarriage in women with the PCOS has been attributed to the insulin resistance and hyperinsulinemia. However, meta-analysis of the 7 randomized control trial of the metformin and insulin hypersecretion, the high insulin sensitizing agent in the woman with PCOS and infertility, showed that metformin has no effect on the sporadic miscarriage risk when administered pre-pregnancy. And uncontrolled small studies have shown that the use of the metformin during pregnancy is associated with a reduction in the miscarriage rate in the woman with recurrent miscarriage with PCOS. However, there is no randomized control trial to assess the role of the metformin in women with the recurrent miscarriages. Now, immunotherapy. Paternal cell immunization, third-party donor leukocytes, and trophoblastic membrane and intravenous immunoglobulin in the woman with previous unexplained recurrent miscarriages does not improve the live birth rate. Now, Cochrane's systemic review has shown that the use of the various forms of the immunotherapy, including the paternal cell immunization, third-party donor leukocytes, trophoblast membranes, and intravenous immunoglobulin in the woman with unexplained recurrent miscarriage, provide no sufficient beneficial effect over placebo in preventing further miscarriages. A 2010 meta-analysis confirmed this conclusion with the respect to intravenous immunoglobulin. Moreover, the immunotherapy is expensive and potentially serious adverse effects, including the transfusion reaction, anaphylactic shock, and hepatitis. The use of immunotherapy should no longer be offered to the woman with unexplained recurrent miscarriages. There is no data on the use of the anti-tumor necrotic factor agents to improve the pregnancy outcome in a woman with recurrent miscarriages. Furthermore, anti-tumor necrotic factor agents could potentially cause serious morbidity, including lymphoma and granulomatous disease such as tuberculosis, demyelinating disease, and congestive cardiac failure and syndrome, similar to SLE. Immune treatment should not be offered routinely to the woman with recurrent miscarriage outside the formal research studies. Now, inherited thrombophilia. There is insufficient evidence to evaluate the effect of the heparin in pregnancy to prevent the miscarriage in the woman with recurrent first trimester miscarriage associated with inherited thrombophilia. Now, heparin therapy during pregnancy may improve the live birth rate of the woman with second trimester miscarriages associated with the inherited thrombophilia. And the efficacy of the thrombophylaxis during pregnancy in the women with recurrent miscarriages who have inherited thrombophilia but who are otherwise symptomatic has not been associated with the prospective randomized control trial, and cohort studies have suggested that heparin therapy may improve the live birth rate for these women. One prospective randomized control trial demonstrating the efficacy of the low molecular weight heparin enoxaparin for the treatment of the woman with a history of the single late miscarriage after 10 weeks of gestation, who carry factor V laden or prothrombin gene mutation or have protein as deficiency. The live birth rate of women treated with enoxaparin was 86% compared with the 29% in the women taking low dose aspirin. Now, unexplained recurrent miscarriages. Women with unexplained recurrent miscarriages who have an excellent prognosis for the future pregnancy outcome with a pharmacological intervention if offered supportive care alone in the setting of a dedicated early pregnancy assessment unit. Tender loving care. A significant proportion of the cases of the recurrent miscarriages remain unexplained. Despite detailed investigation, these women can be reassured that the prognosis of the successful future pregnancy with a supportive care alone in the region of 75%. Okay, is in the region of 75%. However, the prognosis worsen with increasing maternal age and the number of previous miscarriages. The value of the psychological support in improving the pregnancy outcome has not been tested in the form of the randomized control trial. However, data data from the several non-randomized controlled trials have suggested that the attendance at the dedicated early pregnancy clinic has a beneficial effect, although the mechanism is unclear. Now, coming to the role of the aspirin. Aspirin alone or in combination with the heparin is being prescribed for the woman with unexplained recurrent miscarriages with the aim of improving pregnancy outcome. And two recent randomized controlled trial reported that neither of these interventions improved the live rate among the women with unexplained recurrent miscarriages. However, it should be noted that the both studies included a significant number of the women with only two previous miscarriages, 40% and 57% of the study population, respectively. Empirical treatment. The data suggests that the role of the use of empirical treatment in women with unexplained recurrent miscarriages is unnecessary and should be restricted. And furthermore, clinical evaluation of the future treatment for recurrent miscarriages should be performed only in the context of randomized control trial of the sufficient power to determine the efficacy. So this was all about the guideline of recurrent miscarriages. Thank you so much for your patience.